You're listening to Season 2 of Medscape's In Discussion series on idiopathic pulmonary fibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jeff Swigris, pulmonologist and professor of medicine in the Center for Interstitial Lung Disease at National Jewish Health in Denver, Colorado. Dr. Swigris specializes in the clinical care of patients with interstitial lung disease and directs research centered on how interstitial lung disease affects how patients feel and function in their daily lives, how to best measure those effects, and how quality of life may be improved for patients suffering from interstitial lung disease. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hello, I'm Dr. Jeff Swigris. Welcome to Season 2 of the Medscape In Discussion podcast series on idiopathic pulmonary fibrosis. Today, we're going to discuss pulmonary hypertension in patients with pulmonary fibrosis, a condition we typically label PH-ILD, so pulmonary hypertension and interstitial lung disease. We're very lucky today to have our guest, Dr. Patricia or Patty George. Dr. George is an associate professor and the head of the pulmonary hypertension section in the Division of Pulmonary, Critical Care, and Sleep Medicine at National Jewish Health in Denver, Colorado. Patty, welcome to the Medscape In Discussion podcast.
Thank you, Jeff, and thank you so much for having me today. I've been looking forward to speaking with you.
Yeah, it's going to be a lot of fun. Before we dive into our discussion about PH-ILD, Patty, talk to the audience about what drew you to this field. I know that you have a long history of taking care of patients with advanced lung disease, but why now PH-ILD or pulmonary hypertension more generally?
I think that many of us in medicine, when we decide what field that we're going to go into, what specialty, subspecialty, it really comes from interactions with patients as well as with mentors. I actually started out a lung transplant doctor, a transplant pulmonologist at University of Pittsburgh, UPMC. And my mentor there, Sean Studer, was also a transplant pulmonologist. There was a pulmonary hypertension practice there that was basically cardiology based. And we were setting up this joint clinic, a once a month transplant clinic within pulmonary hypertension, because at the time, pulmonary hypertension patients were disadvantaged by the lung allocation score and all that kind of stuff. So I started getting involved a little bit in pulmonary hypertension there. And he said, this is a really exciting field. It's going places. You should go to Pulmonary Hypertension Association conference. So I went to this conference by Pulmonary Hypertension Association that very uniquely had physicians and researchers alongside patients. And so I felt myself thrust into the pulmonary hypertension community. And there was a lot of meaning about being at a place where in one room we're talking medical jargon and all that kind of stuff, although patients are welcome to join. And in other places, patients are talking about how do I use oxygen? What is it like with lung disease and pH and all that kind of stuff? That's what really got me hook, line, and sinker, just being a part of that community. So I shifted from post-transplant to pre-transplant and then ultimately trying to work towards helping people not need a lung transplant and managing pulmonary hypertension.
That's really cool. And you're right, those conferences are really neat. The pulmonary fibrosis field has the PFF Summit from the Pulmonary Fibrosis Foundation. And you have the scientists and the patients adding their perspective. I think it reminds us all why we do what we do. All right, let's dig into the topic today. So you have a busy pulmonary hypertension practice and you see patients with pulmonary hypertension of all sorts of etiologies. A portion of those will have a background of some form of interstitial lung disease. What's your estimate on the proportion of patients that you see that have ILD as a background and pulmonary hypertension?
That's a very good question. The most common type we see is probably pulmonary hypertension associated with left-sided heart disease in our practice. And that's what people see globally because that's the most common type. But with the interstitial lung disease group here at National Jewish being so active, we have a lot of patients who have lung disease. So of our practice, man, I would estimate somewhere between 10 and 15% perhaps.
Yeah. I always talk about it's like the universe piling on, as if having interstitial lung disease or pulmonary fibrosis isn't bad enough. Now you get pulmonary hypertension on top of that. Why do we think some patients are so unlucky to develop pulmonary hypertension on this background of interstitial lung disease or pulmonary fibrosis?
So that's a very good question. And I think an area of active research, because certainly, as you know, unfortunately, not everybody gets pulmonary hypertension. Old thinking was that it had to do with untreated hypoxemia, but that's definitely not the case, as we can treat people's hypoxemia with supplemental oxygen or going to lower elevation, as we're based here in Denver, and people still have pulmonary hypertension. And so it's likely quite complicated. I've been hypothesizing that there are distinct molecular mechanisms that lead towards these subphenotypes of ILD, that ILD with pulmonary hypertension is the completely different disease than ILD without pulmonary hypertension. It's a very good question in an area of active research, but I don't think we quite know yet.
Because hypoxemia may at least be a risk factor, it seems like paying attention to that and correcting that, if at all possible, is a good idea.
Absolutely. When I first see somebody in clinic, that's one of the first things that we look at, especially if they haven't already come from you guys where you would normally be fleshing that out. A walk oximetry test plus a nocturnal oximetry test and or sleep study is a crucial part because that's one of the at least potentially reversible causes because certainly hypoxemia can cause hypoxemia induced pulmonary vasoconstriction. So we want to get these things off the table before we talk about more advanced therapies.
And that's a nice segue into my next question. So I know that this is really a rapidly evolving area, but talk to us about the current framework of therapies and the treatment strategies that you and your colleagues would use to manage pulmonary hypertension in patients with interstitial lung disease.
Absolutely. So, pulmonary hypertension associated with ILD, PH-ILD is a tough diagnosis, as you know. One of the first things that we do in clinic is work on talking with patients about expectations. When we go after pulmonary vascular disease with medications, it's important to know that at the end of the day, they still have pulmonary fibrosis. And what's challenging is if you give somebody a medical therapy, they may think, okay, this is going to make me better. We have to define what better is together with that patient because the truth of the matter is they'll still have their disease and they'll still be symptomatic. There's nothing curative right now aside from lung transplantation, and we can talk about that separately because there's pros and cons, of course, of lung transplant. The first thing we do is we talk about it as joint decision making and setting joint expectations with the patient about what this means. And I phrase it with people and talk to people about how, okay, you have this disease here, and we don't have the ability to take you to how you felt prior to your diagnosis of PH-ILD, especially of ILD. However, if we do several steps, we can get you to at least a better place and hopefully a better quality of life than where you are right now. And so those things include what are you doing for your interstitial lung disease? Are you on medical therapy? Certain forms are more treatable or responsive to therapies than others from a symptomatic perspective. So are they on treatment for that? Are they using supplemental oxygen? That's crucial because that, as we mentioned, does contribute to narrowing of the pulmonary arteries and increased symptomatology and fatigue and the things that bother people. Are they exercising? Have they done pulmonary rehab? At our center, as you know, we're very pro pulmonary rehabilitation, getting people moving, building whatever cardiovascular fitness, cardiopulmonary fitness that we can to help with oxygen extraction at the muscle level, for example. And also learning compensatory techniques so they know how to pace themselves, how to breathe themselves through difficult settings. What's their nutritional status like? Are they undernourished or do people have type 2 diabetes and obesity that also impinges on their ability to breathe? Maybe their hypoxia signaling maybe also gives them a little stiffness of the left side of the heart, diastolic dysfunction. So, as you know, we have a program here that really works on improving metabolic health to try to help people lose weight and breathe better. What are people doing in terms of mental health? How are they approaching anxiety and challenges around shortness of breath and also complicated lifestyle? What about comorbidities? Are they treating their GERD? Are they treating these other contributors? Last but not least, when we get into therapeutics, specifically directed at PH-ILD, and we're talking about new medications in this field. We have inhaled treprostinil, inhaled prostacyclin medications, and that's been quite exciting. So prior to this trial called the INCREASE trial, practice patterns were pretty nihilistic when we talk about PH-ILD. People would even avoid getting a right heart cath unless they were going for lung transplant, because why get a heart cath? There are no therapies that are approved. And in fact, there's a whole list of therapies that have been shown not to help or even cause harm in people with PH-ILD. And so for a long time, many practitioners might not even look or screen or do anything. It was different here because we've been a little bit forward thinking, I think, and aggressive. But understandably, even the guidelines did not say, hey, make sure you get a heart cath and flesh this out, because we didn't have effective therapies other than transplant. And then the INCREASE trial, which was a trial looking at inhaled treprostinil, was our first positive study in patients with PH-ILD. This is an inhaled medication via nebulizer that people take 4 times a day. They take several breaths, 3, 6, 9, and up to 12, 15 breaths 4 times a day. Some people push higher. The primary outcome was improvement in 6-minute walk distance. So at 16 weeks, between those who got medication and those who got placebo, there was a 31-meter difference in 6-minute walk distance, which we think of as clinically meaningful. There were a lot of secondary benefits as well that were kind of intriguing and actually are the subject of a current ongoing clinical trial. Things like decreased frequency of exacerbation of pulmonary fibrosis, decline in lung function, like things that you wouldn't necessarily associate with an inhaled pulmonary vasodilator, but certainly exciting. So it was a really promising study. Prior to this, a lot of us in the field, not just at National Jewish, would use this medication off label because it made sense. Okay, if I'm going to give you an inhaled medication that targets your blood vessels in your lungs, it's going to get absorbed, hopefully at the healthiest areas of the lungs, which is where we want to dilate those blood vessels. Maybe we won't have as much ventilation perfusion mismatch, things like that. In our hands, it seemed to work well. And a lot of people did that. It was nice that we had a clinical trial that then supported these practice patterns and then have made them more widely utilized. So it's a medicine that can help people feel better too. Sometimes when you put someone on an antifibrotic, it's not necessarily like people with asthma taking albuterol and instantly feeling better, right? They don't necessarily feel better. But with inhaled treprostinil, provided we manage people through side effects, people can actually feel better and do a little more and have a little more energy in their day-to-day activity, which is consistent with what that trial showed. That's become a cornerstone of our therapies, but it's laced on top of the other stair steps, which are important to address. Finally, transplant referral. If anybody has PH-ILD and they're potentially a candidate for lung transplant, then early referral for transplant, even if we're prescribing treprostinil, is a good idea because it won't be curative. It'll help people feel better. There's no study saying that helps people live longer, but early referral to transplant becomes important as well. So there's a lot of steps in the treatment of somebody with PH-ILD, not just medical therapy. One last thing, along with mental health, is early palliative care referral. That's citing one of the papers I think you're a co-author on with Kathy Lindell, talking about the importance of palliative care and supportive care. In many chronic diseases, people who have palliative care on board actually live longer with better quality of life. And so we really try to engage those folks as well to truly take care of the entire patient.
I'm so glad you answered that question that way, because when a new drug comes out or we finally have a therapy for a condition that's been so hard to treat for so long, we all get excited like, oh, I'm going to prescribe this new drug. And we forget about all the layers that you talked about that are so important for treating the whole patient. Putting somebody on a drug and not paying attention to their conditioning, to pulmonary rehab, to their oxygen status, to their mental health is just doing them a disservice. So making sure that we're treating the whole patient and not forgetting these things that seem so simple but are so, so critical. It reminds me of when I was a resident in the ICU, we would have an attending and you're always replacing potassium or magnesium or adjusting sodium and so forth. These little things that seem so mundane. And I remember an attending just paying so much attention to serum potassium, and he wanted it in this very tight range. And, as a resident, you're like, oh, come on, this is just potassium. But these are the things that matter to patients' quality of life, to giving them the best life possible given their circumstance. Pay attention to the little things. You'll always have the opportunity to prescribe the new drug, but don't forget these other things that seem so little but are so important.
Absolutely.
You mentioned right heart catheterization. Why can't I just put a patient on inhaled treprostinil? Now, this thing is FDA approved for patients with PH-ILD. What's the harm in putting them on this therapy and not actually having them go through a right heart catheterization?
Really great question, because sometimes people do that. Right now, you're able to get sildenafil is generic, right? So if they have pH on echo, oftentimes some patients will come to us on a PDE5 inhibitor because you can, but just because you can doesn't mean you should. And let's talk about that. So one of the things we do here at our center, both your group and our group, is we obsess in a good way about phenotyping, because you need to know exactly what you're treating before you treat it. And for those who don't do as much pulmonary hypertension, the quick framework is there are multiple types of pulmonary hypertension, right? So when people Google or quick do a web search of pulmonary hypertension, they mainly read about PAH, which is not what we're talking about. This is people without interstitial lung disease. The second type of pulmonary hypertension is pulmonary hypertension due to left sided heart disease. We call that group 2 PH. And in this day and age, it's people who have HFpEF, heart failure with preserved ejection fraction, which we see a lot of. Some risk factors for HFpEF include age, perhaps smoking history, hypertension, which, by the way, are a lot of comorbidities that our patients may have who have interstitial lung disease. The third type is pulmonary hypertension with ILD. The fourth type is pulmonary hypertension due to chronic obstructions, namely blood clots. And then the fifth category is this miscellaneous category. So the right heart cath becomes really essential, because when I see patients, I'm like, do they really have group 3? Is this really what we call a pre-capillary picture? The numbers in group 3 pH, meaning in PH-ILD, the hemodynamics look the same as in group 1. If, however, you do a heart cath and their pulmonary capillary wedge pressure is 18 or 20, this person really may have concomitant heart disease and HFpEF or diastolic dysfunction or any form of heart disease. And so if I were to just not know those numbers and prescribe a pulmonary vasodilator, which is going to increase the preload that now the left side of the heart is going to see, we can make someone feel worse rather than better. The other thing, too, is we do want to know what those numbers are before we start treatment. Because let's say you just start a treatment and you have no idea what the hemodynamics are. And then a year later or 2 years later, they feel worse. Is it their pulmonary hypertension? Is it their ILD? As you know, it's hard to characterize which aspect is getting worse. It's important to know that, right? Because it may be something that our pulmonary hypertension team has to work on, or it may be something that needs to be worked on by the people addressing the parenchymal issues. It's really important to get that baseline set of numbers to make that right phenotype, that accurate diagnosis. What if they don't have pH and it's just the echo, which oftentimes isn't accurate? Well, now you get to at least save them a medication that has side effects and it's expensive and it's stressful and they have to get patient assistance programs. All that kind of stress that's real for our patients, we certainly don't want to inflict that without certainty that this medication could be beneficial.
Do you use sildenafil in PH-ILD?
Yeah, sometimes off label. There was a clinical trial, STEP IPF, that showed that perhaps it helped people in terms of exercise tolerance. Like the primary outcome was negative, but maybe there's a signal there. Do I routinely do it? No, it's not necessarily FDA approved. But if I have someone who wants to try something, we've phenotyped them, they've had their heart cath. I've tried to encourage inhaled treprostinil. That's first line medical therapy from us. Maybe they've tried it, or maybe they refuse to do something 4 times a day. Then sometimes we'll talk about a trial of an off label therapy. When we do, this is never a set it and forget it. If we start any sort of therapy, even like an off label PD5 inhibitor, we're going to be monitoring them closely. Because again, sometimes, no matter the type of pH, you elucidate a left sided heart disease once you put them on pulmonary vasodilators. So you really have to start a therapy and see them quite frequently after.
Yeah, STEP IPF also had a signal. Patty mentioned STEP IPF. This was a trial in patients who had idiopathic pulmonary fibrosis, severe by physiological criteria. I think DLCOs were less than 25% or something like that. And the thing that I liked about that trial, as you mentioned, yes, it's true. They did not hit their primary endpoint, which was 6-minute walk distance. They were looking for a 20% improvement in 6-minute walk distance. But what they saw in patients who were treated with sildenafil relative to placebo was actually improvements in dyspnea and other symptom scores. So I sometimes reach for that therapy in my very late severe patients who may or may not have pulmonary hypertension. How do you follow a patient? So if you put them on, let's say, inhaled treprostinil or whatever it might be, how are you going to follow those patients other than talking with your ILD colleagues? And we're so lucky to be able to co-manage patients with you and your group. That obviously becomes a really important piece of it. But just walk us through like a general approach to treating patients with PH-ILD.
In addition to setting expectations, this initiation of that medication involves talking about not only expectations of how you should improve, but also expectations of potential side effects that one will encounter. There are several that class of medications, the prostacyclin class, can cause and prostanoid pathway can cause. So, headache, jaw pain, flushing can affect systemic blood pressure, these kinds of things. In the inhaled form, we tend to see less of what they call off target side effects. But the one thing that we see a lot of is cough. And so from the outset, we are working with them on developing strategies to anticipate and how to mitigate the cough. And a lot of these patients, right, they have a cough. Not everybody, but a lot of people with ILD have cough. It's not usually a worsening or the same ILD cough. It's actually like an irritant cough up higher in their airways or a throat cough. We can mitigate it by doing things like have them gargle, drink something cold, drink something hot, take some yogurt, coat the throat. And it's a cough that happens around the time of getting the medication, like 15 minutes, maybe a half hour. It shouldn't be longer than that. It can be a big impingement on quality of life. So we come up with a strategy for the cough. When I say we, it's not me as the doctor or our physicians, but it's also our nursing team. So we pass the baton before they leave, and the nurses come in and do their education. And they'll often start out with, I know you just spoke with Dr. George. Can you tell me what you heard? Because it's amazing whether it's us speaking doctor speak or them trying to absorb something for the first time. It's very challenging. So we try to be repetitive in educating and working with patients. So the nursing component is huge. They also will be following up very frequently by telephone on a weekly basis after starting this medication to see how are you doing, et cetera, and talk about dose increase. We usually start people on 3 breaths 4 times daily, and then we'll increase by a breath a week if they can tolerate it to get up to 12, 15 breaths, sometimes more. They also get educated by specialty pharmacies who go out and they actually show them the device and do the hands-on education. How do you program it? All that kind of stuff. They also will educate on side effects and how to mitigate side effects. And so it's this multifaceted team that gets them on medication. And then in general, in pulmonary hypertension, we see people every 3 months. If they're sicker, we may see them sooner than that. If they've been on therapy for a long time, and it's a bit of a loaded term to say stable, because in a chronic progressive disease, what is stable? In some patients, we might see them every 6 months, but by and large, we're following people every 3 months. In the clinic, there's a lot of in between phone calls from our nursing team that helps make sure our patients are safe and feeling good on medications.
And when you see them in clinic, Patty, you want to see a 6-minute walk? Do you typically order physiology? I mean, I typically follow my ILD patients every 3 months, also spirometry, diffusing capacity, 6-minute walk. And so obviously we don't want to put patients through the ringer too much and have them double pulmonary physiology stuff. What's your approach there on pulmonary physiology and 6-minute walk test?
Yeah, absolutely. Every time they come, we get a 6-minute walk test, and we'll look not only at their distance, but how much are they desaturating, their distance saturation product. We'll also look at spirometry and DLCO. Like sometimes we see a little improvement in diffusing capacity. Maybe the VQ is improving for us to see that, and that can be encouraging. We get an echocardiogram on average every 6 months, sometimes 3 months if someone's sick, but usually every 6 months. We don't tend to just arbitrarily repeat right heart caths. If somebody's getting worse, we might. Maybe the medication's not working. Maybe it's overdoing all those kinds of things. So, right heart cath, it's sort of a physician's choice based on how they're doing. And of course, most importantly, talking to the patient.
For my final question now, we'll reach out to the real cutting edge here of your field. And the topic is exercise induced pulmonary hypertension. And I know this is a topic that is in evolution, but should we be looking for this more? How do we test for it? What do we do about it? What do you and folks in your field think about exercise induced pulmonary hypertension?
That's a great question. It's a super exciting topic. And as you know, we have an active center here doing exercise right heart caths, exploring this. Should you screen for it? That's a loaded question. So, what are the things that could cause pulmonary hypertension with exercise? So, number one, hypoxemia. Number two, underlying lung disease. Number three, somebody could have diastolic dysfunction. So, oftentimes people may have an exercise echocardiogram or a stress echo that was done maybe for an ischemic eval, and they note, oh, RVSP went from 30 to 50. Is this exercise pH? So, we'll get these consults. The other way we get them is they're looking for causes of hypoxemia and they'll do an exercise bubble study and boom, you see an elevated RVSP. So we get these consults. And there are various ways to quote exercise people at the time of right heart cath. However, the gold standard is by using a formal level 3 CPAT, like a cardiopulmonary exercise test with a bicycle. Some people do supine, upright. We do ours as an upright bicycle, same as you would do in the exercise physiology lab over here in clinic. And of course, assess hemodynamics. And what's really interesting about it is very rarely do we diagnose exercise PAH. So sometimes patients with those echoes, again, will come to us on sildenafil, but we'll find out that that may not be the most helpful medications. Most of the time, we'll see people with exercise induced like HFpEF group 2, like diastolic dysfunction. But that's super helpful because it gives us an answer. Without that exercise cath, the same patient just will have normal hemodynamics, but they're still short of breath or they're fatigued and they can't do stuff. So I like the test. We like the test because it helps us really say, okay, your symptoms are when you're exercising. So we need to provoke you and figure out exactly what's happening when you're exercising. So that's how this test, just like a non invasive CPET, can be really helpful because you see what happens and you get data from exercise. During COVID, we oftentimes would see people with preload insufficiency and a lot of people who had dysautonomia. And that sealed a diagnosis. And that was before we had really super fancy tilt table testing now. But at the time, we didn't really have that. And so we were making these diagnoses more based on a lack of augmentation and right atrial pressure and wedge pressure and stuff with exercise. And so you just see people bottom out with exercise. That was extremely helpful. So I think the test is very informative. You wouldn't get those results with other forms of exercise. So some people say, I'm going to get saline bags or hand weights and I'll have them do this on the table and reassess the numbers. That's less helpful. It really has to be this formalized, true level 3 CPET, or maybe it's a recumbent or a supine bike, but some form of that kind of exercise can be very helpful.
Wow. That's a lot to take in and really an exciting area. And I can't wait to see where that evolves to over time. We have reached the end of our time together. I thank Patty George for joining us today and talking about pulmonary hypertension in the setting of interstitial lung disease. And the big takeaways here are there is a therapy for that condition and probably or perhaps more on the way. And by therapy, I'm talking about a drug therapy. But Patty reminded us that it's not just about drug therapy when there is pulmonary hypertension and ILD. We want to remember all of the other things, the so called little things that actually are quite big and very important. And those include fixing hypoxemia, assessing for nocturnal hypoxemia, sleep disordered breathing, exercise, nutrition status, treating comorbidities, and of course, paying attention to patients' mental health. Following these patients over time, you probably heard us mention multidisciplinary. Find a doc who specializes in pulmonary hypertension and team up with them because a team approach for these complex patients is absolutely the best way to go. If you put patients on drugs for PH-ILD in much the same way that putting patients on drugs for ILD in general, it's not a write it and forget it. These patients require close follow up to manage side effects, to manage expectations, and to follow metrics that are important, whether they're physiological or functional, in addition to talking to patients and hearing about their quality of life and their symptoms. We touched just a little bit on exercise induced pulmonary hypertension, which is really an evolving topic, and much more to come on that. So, Patty, thank you so much for joining me today. It was really wonderful having you here, and we sure appreciate hearing your expertise and your approach to these really complex patients.
Thank you, Jeff. It was a pleasure.
And thank you all for tuning in. Please take a moment, if you would, and download the Medscape app to listen and subscribe to this podcast series on idiopathic pulmonary fibrosis. I am Dr. Jeff Swigris for the Medscape in Discussion podcast.
Thanks for listening to Season 2 of Medscape's In Discussion Idiopathic Pulmonary Fibrosis podcast series with our host, Dr. Jeff Swigris. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on idiopathic pulmonary fibrosis.